Esophageal resection, there are multiple approaches depending on the location of the tumor and the lymph nodes that are involved. The three primary approaches would be an Ivor-Lewis esophagogastrectomy, a McEwen or three-holer esophagogastrectomy, and a transhiatal esophagogastrectomy. These approaches just basically are fancy ways of saying where we make our incisions and how we approach the tumor. All of the approaches include an abdominal incision, which allows us to mobilize the stomach because we're going to remove the esophageal cancer. Most of the esophageal cancers we see are in the distal esophagus and involve sometimes the proximal stomach. Most of the cancers at what we call the GE junction between the esophagus and the stomach. So we have to remove a portion of the stomach, usually about 1/3 of the stomach, and 2/3 of the esophagus to get excellent margins to have all the tumor out and clean all the lymph nodes out with that. So all the approaches include an abdominal incision that allow us to mobilize the stomach so we can both remove that portion of the stomach with the cancer, and then we make the stomach a new esophagus. And we bring the stomach into the chest and connect it to the esophagus as a new tube so that you're able to go back to eating normally. Ivor-Lewis esophagogastrectomy includes an abdominal incision and a chest incision. So once we've completed the abdominal portion, we then make a chest incision and bring the stomach into the chest and connect it to the esophagus. The three-holer procedure, or the McEwen procedure, is used when a patient has an esophageal cancer that's higher up in the esophagus, and it requires more tedious dissection in the chest. So typically we start in the chest, we mobilize the esophagus and drain all and resect all the lymph nodes, and then we go into the abdomen to mobilize to make our stomach the new conduit, and then we bring it all the way into the neck, and you'll have a left neck incision where we reconnect the anastomosis in the neck. The transhiatal esophagogastrectomy is usually when there's not much disease in the chest. We're not concerned about lymph nodes, we're not concerned about the tumor in the chest, and we're actually able to reach the stomach from the abdomen all the way to the neck and make our incision, so you'll only need an incision in the abdomen and the neck and not an incision in the chest. All of these determinations are made by our preoperative assessment based on the location of the tumor and any other structures involved and the amount of lymph node disease that needs to be resected. Esophagogastrectomy is one of the top 10 biggest operations that a person can have. Typically the standard risk, as in any generic surgery, would be infection, bleeding, heart attack, stroke, blood clots, pneumonia, and death. Complications more specific to esophagectomy include a leak at the anastomosis, which is the connection between the esophagus and the stomach. A stricture, which is a narrowing or scarring of the anastomosis, which is the connection between the esophagus and the stomach. Some of the side effects of surgery include dumping, delayed gastric emptying, reflux, aspiration, and dysphagia.